I'm Angel.
And I'm Jarek, and today we'll be presenting on a critical acute complication of diabetes mellitus called diabetic ketoacidosis or DKA. This is a serious and potentially fatal condition if not treated immediately.
DKA is most commonly associated with type 1 diabetes mellitus, but it can also happen in type 2 in other conditions such as severe stress like infection, surgery, or trauma.
It occurs when the body lacks enough insulin to utilize glucose. Since glucose can't enter the cells, the body switches to fat metabolism for energy. This process produces ketones, acidic substances that causes metabolic acidosis when they accumulate in the blood.
This condition is a medical emergency and requires urgent treatment to correct three main issues: hyperglycemia, dehydration, and acidosis.
DKA is characterized by three hallmark features. One is hyperglycemia, where the blood glucose is greater than 250 milligrams per deciliter. Two is that ketosis, the presence of ketones in the blood and urine. Three is the metabolic acidosis, or the arterial pH level is less than 7.3 and the serum bicarbonate is less than 18 milliequivalents per liter. Let's break each down. Hyperglycemia occurs to the lack of insulin, which prevents glucose from entering cells. The liver responds by producing more glucose through gluconeogenesis and glycogenolysis, thinking that the body needs energy. However, since insulin is lacking, glucose continues to build up in the bloodstream. Once it exceeds the kidney's capacity, it spills into the urine, a process called glycosuria. The glucose in the urine pulls water and electrolytes with it, leading to osmotic diuresis, causing a significant dehydration and electrolyte imbalance like sodium and potassium. Meanwhile, due to the unavailability of the glucose, the body starts breaking down fat into free fatty acids, which the liver converts into ketones, specifically acetoacetate and beta-hydroxybutyrate. These ketones are acidic. When they accumulate in the blood's acidity level drops, resulting in the metabolic acidosis. To compensate, the body triggers the small respirations, the deep, rapid breathing to expel carbon dioxide and raise the blood pH. If left untreated, the acidosis can worsen, leading to confusion, lethargy, and potentially coma or death.
Now let's talk about the risk factors for diabetic ketoacidosis. DKA doesn't just happen in a vacuum. There are specific conditions that either increases the body's demand for insulin or interfere with insulin supply, triggering the onset of this dangerous complication. Being aware of these risk factors is essential for both prevention and early intervention, especially in high-risk populations like children, adolescent, or newly diagnosed individuals. One of the most common causes is related to insulin itself. One is missed insulin doses or poor compliance. Without adequate insulin, glucose cannot enter the cell, so the body switches to fat metabolism, resulting in ketone production and acidosis. Next is insulin pump malfunction. If the pump fails or the infusion site is dislodged, insulin delivery stops, leading to rising blood glucose and risk of DKA. Another is undiagnosed diabetes, especially in children or adolescents, where symptoms can go unnoticed until DKA is the first clinical presentation. Next are stress-related causes, which increase counter-regulatory hormones like cortisol, epinephrine, and glucagon. Number one is infections, particularly with UTIs and pneumonia, are among the top triggers of DKA. Another is surgery, trauma, or any major physical stress can drive glucose levels up while suppressing insulin action. Another is myocardial infarction or heart attack or stroke can also lead to DKA due to stress hormone release and increased insulin resistance. Next is hormonal influences. During times of hormonal changes like puberty or pregnancy, the body naturally becomes more resistant to insulin. This resistance, along with a poor glycemic control, can tip the balance towards DKA, especially in type 1 diabetes. Next is medications. Certain medications can inadvertently raise blood sugar glucose or impair insulin function. One is glucocorticoids, which stimulate glucose production. Another is diuretics, which promotes fluid loss, increasing blood concentration and leading to dehydration, which worsens hyperglycemia. Next is atypical antipsychotics, which may cause insulin resistance and weight gain. And lastly, sympathomimetics like albuterol raises stress hormone levels, spiking blood sugar. Next is substance use can also be a hidden factor. Excessive alcohol can initially lower blood glucose but impair liver function over time, contributing to ketosis. Another is illicit drug use like cocaine and ecstasy can raise glucose and interfere with the insulin, increasing the DKA risk. DKA is also linked to emotional and behavioral health. Eating disorders, particularly in adolescents with type 1 DM, are a serious concern. Intentional insulin omission to control weight puts patients in extreme risk. Another is emotional stress, such as anxiety or family conflict, triggers hormonal responses that increases blood glucose and reduce insulin effectiveness. So one key point. Children and adolescents are particularly vulnerable, especially during puberty or growth spurts, where insulin needs increases and hormonal shifts complicate glycemic control. Recognizing and addressing these risk factors can mean the difference between early intervention and a life-threatening DK crisis.
Let's now dive deep into the storm that brews inside the body during diabetic ketoacidosis or DKA. As we all know, the core issue here is an absolute or relative insulin deficiency. This can happen if the patient forgets insulin doses, experiences an illness, trauma, surgery, or even emotional stress. Why? Because these stressors can stimulate the release of counter-regulatory hormones, glucagon, cortisol, catecholamines, and the growth hormone. These hormones act like insulin's enemies. They counter insulin's function and they signal the liver to increase glucose production via glucogenesis and glycogenolysis. But there's a catch. The glucose produced has nowhere to go. With no insulin to open the cellular doors, glucose accumulates in the bloodstream, leading to hyperglycemia. And since the cells can't use this glucose, the body panics. It starts breaking down fat for energy, a process called lipolysis. This leads to the release of free fatty acids, which travel to the liver and are converted into ketone bodies. These ketones are acidic, and as they build up, the blood becomes dangerously acidic, leading to metabolic acidosis. Now let's paint the full picture of this pathophysiologic cascade. First, low insulin, cells can't absorb glucose, and then the cells starve. Next is that the liver responds by making more glucose, worsening hyperglycemia. The body switches to fat metabolism, which lipolysis occurs. Then free fatty acids are converted into ketones, causing ketoacidosis. Meanwhile, the excess glucose in the blood surpasses the renal threshold. The kidneys try to remove it. Glycosuria happens. Glucose in the urine drags along water. This is called the osmotic diuresis. The result, polyuria, dehydration, and major electrolysis, especially in sodium, potassium, and chloride. And the consequences don't stop there. The patient becomes dehydrated and acidotic, which triggers a compensatory respiratory response, what we call small respirations, those deep, labored breaths trying to blow off carbon dioxide and raise the pH. But if DKA continues to be unchecked, things can go downhill fast. Tachycardia and hypotension set in due to volume loss, and the brain starts to suffer from the acidosis and dehydration. The result, altered mental status progressing to lethargy, coma, or even death if not treated urgently. So to wrap this up, the pathogenesis of diabetic ketoacidosis is a domino effect of insulin deficiency, hormonal imbalance, cellular starvation despite having a high blood sugar, ketone buildup, and metabolic acidosis, severe dehydration, and electrolyte loss.
Now let's review the signs and symptoms commonly seen in DKA. One is weight loss due to fat and muscle breakdown. Another is nausea and vomiting linked to acidosis and dehydration. Abdominal discomfort and cosmal breathing, which is a deep, rapid breathing as the body tries to compensate for acidosis. Another is fruity breath odor from ketone exhalation. Another is altered mental status like confusion, drowsiness, or even worse, coma. Another is polyphagia, which is increased hunger despite the weight loss. Next is polyuria, which is frequent urination due to osmotic diuresis. Another is polydipsia, which is excessive thirst. And lastly, signs of dehydration like dry skin, decreased urine output, hypotension, and tachycardia. Now, these manifestations point to cellular starvation, fluid imbalances, and metabolic distress requiring immediate intervention. Now, to diagnose DKA, we use a combination of clinical assessment and laboratory values. The classic diagnostic triad includes, number 1, hyperglycemia. This is when blood glucose is more than 250 milligrams per deciliter. This reflects the inability of insulin to promote glucose uptake into cells. Because glucose remains in the bloodstream, the kidneys try to excrete it, leading to osmotic diuresis, dehydration, and electrolyte loss. Number 2 is metabolic acidosis. This is when arterial pH is less than 7.3 and serum bicarbonate is less than 18 milliequivalents per liter. So ketone bodies are acidic and accumulate in the blood due to fat metabolism. This drop in pH and bicarbonate signals uncompensated metabolic acidosis. Number 3 is ketonemia or ketonuria, moderate or to high ketones in serum or urine. This indicates that the body has shifted from carbohydrate to fat metabolism due to insulin deficiency. Labs may measure serum ketones or use dipstick testing for urine ketones. Now, besides the triad, other lab values help us assess the severity and monitor progression. First up, we have electrolytes. In potassium, this may be high, normal, or low initially. But insulin therapy causes intracellular shifting of potassium, so levels must be carefully monitored to prevent hypokalemia. Next is sodium, which often appears falsely low due to hyperglycemia. Next is anion gap, which is greater than 12 milliequivalents per liter. This indicates high anion gap metabolic acidosis due to unmeasured ketone acids. Next is BUN and creatinine, which is elevated due to dehydration and pre-renal azotemia. Next, we have serum osmolality, often mildly elevated, which helps differentiate from hyperosmolar hyperglycemic state, which has higher osmolality but minimal ketosis. Now, to summarize, the hallmark diagnostic features of DKA include, number 1, glucose, which is more than 250 milligrams per deciliter, pH that is less than 7.3, serum bicarbonate, which is less than 18 milliequivalents per liter, positive ketones, and elevated anion gap.
There are 3 primary goals when it comes to medical management of DKA. One is the fluid resuscitation to correct dehydration. 2 is the insulin therapy to reduce blood glucose and suppress ketone formation. And 3 is the electrolyte correction, especially potassium, using isotonic saline of 0.9% or 0.45% depending on the sodium levels. Administer insulin IV, but don't start insulin if the potassium is below 3.3 milliequivalents per liter. Potassium must be monitored closely. Insulin pushes potassium into cells, risking hypokalemia, which can be fatal. Let's briefly go through a detailed explanation of the diagnosis and interventions. For weight loss, the nursing diagnosis for it is the imbalanced nutrition less than the body requirements. The key intervention for it is to monitor weight, give insulin fluids, and a dietitian referral. For nausea and vomiting, the risk for fluid volume deficit, the key intervention is to monitor input and output give antiemetics as prescribed, and give comfort care. For small breathing or the infective breathing pattern, you have to monitor the respiration rate, the O2 saturation, and provide supplementary oxygen. For ketone breath or the risk for imbalanced nutrition, monitor glucose and hydrate and give insulin as prescribed. For confusion, with the nursing diagnosis of acute confusion, you need to reorient the patient, monitor the labs, and ensure safety. For polyphagia, or the imbalanced nutrition more than the body requirements, is to monitor glucose and to have a dietary plan. For polyuria, the risk for fluid volume deficit, the key intervention is to replace fluid via fluid replacement therapy and monitor output. For polydipsia, the risk for fluid volume deficit, you have to encourage fluids and educate on hydration. For dehydration or a deficient in fluid volume, which could lead to a deficient in fluid volume, you have to have IV fluids or IV cannulation of prescribed IV fluids, oral hydration, and always assessment of the vitals.
For nursing management, first we have to monitor vital signs closely. This includes blood pressure, heart rate, respiratory rate, and temperature. Patients with DKA commonly present with hypotension due to dehydration, tachycardia as compensatory response, and tachypnea, including osmolar aspirations, as the body tries to correct the acidosis. Next, we monitor blood glucose levels frequently. The goal is to observe a steady decline in glucose as treatment progresses. We also perform regular arterial blood gas to test and check for metabolic acidosis and to monitor bicarbonate and pH levels. Next is monitoring electrolytes. We focus on potassium, sodium, chloride, and bicarbonate, which can shift rapidly during DKA. Fluid and electrolyte management. Managing fluids is the first major intervention. We usually start with a IV normal saline 0.9% to correct dehydration. If the patient has elevated sodium, we might opt for 0.45% saline instead. Fluids must be given gradually to prevent complications like cerebral edema, especially in children. Then we correct electrolyte imbalances, especially potassium. Even if the serum potassium looks normal at first, it can drop dangerously once insulin therapy begins. That's because insulin causes potassium to shift into cells, lowering blood potassium even further. So in summary, managing DKA is all about careful monitoring, judicious fluid replacement, and tight electrolyte control, especially potassium. That's how we stabilize the patient and prevent complications during recovery.
Now it's time to shift to a critical part of patient care, monitoring for complications. Yes, DKA management doesn't end with giving insulin and fluids. In fact, complications can arise during treatment, and if we don't monitor closely, we could trade one emergency for another. Let's start with one of the most serious complications, the cerebral edema. Though rare, it is most common in children and adolescents, and it can be fatal if not caught early. Next is hypoglycemia. Once insulin is started, glucose levels can drop rapidly, especially if fluid resuscitation has already begun to dilute the blood glucose. So, frequent blood glucose monitoring is essential. And lastly, don't forget about hypokalemia. Here's the catch. DKA often presents with elevated serum potassium, but this is misleading. Once insulin is given, potassium is driven into cells, unmasking the total body potassium deficit. Without careful replacement, patients can develop arrhythmias or muscle weakness. So, always replace potassium as per protocol unless the patient is hyperkalemic with an EKG changes or has renal impairment.
Education is key in preventing future episodes. Once the patient stabilizes, we begin comprehensive diabetes self-management education. We teach patients 1. How to administer insulin properly, 2. The importance of routine glucose monitoring, 3. Dietary guidance including carb counting, and 4. And most importantly, how to identify early signs of DKA like nausea, abdominal pain, and fruity breath. Under prevention, we emphasize sticking to prescribed insulin regimen, monitoring signs for infections, and staying hydrated, especially during illness or stress. But let's not forget, DKA isn't just physically exhausting. It is also emotionally overwhelming, especially for newly diagnosed patients or children. We should provide reassurance, answer their questions with empathy, and involve both the patient and family in care planning. Let them feel like they are in control again. We also collaborate with multidisciplinary team like physicians, diabetes educators, and dietitians to give patients all the tools they need for long-term success. So in summary, treat DKA fast, but monitor even faster. Educate with heart and support the patient as a whole person, not just a diagnosis. That's the core of DKA nursing care. Clinical vigilance, proactive education, and compassionate support. To summarize, DKA is a life-threatening condition, but with prompt recognition and proper management, it is entirely treatable.
Nurses play a vital role in monitoring, patient education, and prevention. Let's stay vigilant and proactive.
Thank you for listening.